Welcome to the Acute Medical Teaching Series. We are your hosts, Shifona
and Harrison,
both senior house officers from Salisbury District Hospital. This is a 12-part teaching series running over 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students. This is our 9th session and we will be looking at the management of hyperkalaemia.
So what is hyperkalaemia? Hyperkalaemia is defined as potassium levels greater than 5.5 within the blood. However, only when potassium levels reach greater than 6 in the blood do we become concerned about treatment, as clinical manifestations are uncommon beneath this point. Our primary concern with high potassium levels is the risk of ECG changes, which we will go over later, which have the potential to progress to life-threatening arrhythmias.
So what causes hyperkalaemia? Hyperkalaemia is generally secondary to either increased intake of potassium or decreased excretion of potassium, or potassium shifts between cells and extracellular fluid. Regarding increased intake of potassium, this can be secondary to the patient's diet, for example, foods rich in potassium such as bananas, or iatrogenic through potassium supplementation such as Sandoz or IV infusions of potassium. Although it is important to note that in the setting of normal renal function, this is unlikely to occur. But in a diseased kidney, they are at increased risk of potassium accumulation.
Regarding decreased secretion of potassium, this occurs in the context of impaired renal function, which leads to the accumulation of potassium. It can occur in both chronic kidney disease and acute kidney injury, and this is due to that kidney's regulatory role in potassium levels within the body. And we know that having an eGFR of less than 30 puts you at particularly increased risk. It can also occur in those with endocrinological disorders such as Addison's disease, and this is due to that deficiency of aldosterone, and that therefore means that the kidneys don't secrete enough potassium.
Drugs can also have an impact on the kidney's ability to excrete potassium. Common medications include potassium-sparing diuretics, for example spironolactone and amiloride. Antibiotics such as trimethoprim can also cause a high potassium. ACE inhibitors and ARBs, these are angiotensin receptor blockers, can also cause decreased potassium secretion. Other drugs include heparins such as dalteparin, which can cause an elevated potassium.
And finally, we will now talk about the causes of hyperkalaemia due to shifts of potassium between the cells and the extracellular fluid. Metabolic acidosis can cause large shifts of potassium from the cells to the extracellular space, and this is due to that increased H+ ion content, and this then essentially, as your body tries to buffer this acidosis, your body will try and shift H+ ions into cells, and as a consequence of this, move potassium ions out of cells, causing a hyperkalaemia. Insulin is also responsible for triggering the cellular entry of potassium into cells, so therefore if the patient is in a deficient state of insulin, for example if they have a diabetic ketoacidosis, this can also cause a hyperkalaemia. We also know that beta agonism facilitates this process of potassium moving into cells. Therefore if someone is on a beta blocker, this can also cause patients to have a hyperkalaemia, although note with beta blockers this would normally be very mild. And this leads nicely into the management of hyperkalaemia, as we can consider options such as insulin therapy and beta agonists, which essentially work in the opposite mechanism of what we've just described to lower the potassium levels.
It is always important to consider pseudohyperkalaemia. Hemolysis in a sample test tube can lead to falsely elevated potassium levels, as potassium is primarily located in cells. So if the high potassium does not fit the clinical picture, results are often repeated.
So in summary, we can therefore consider the causes of hyperkalaemia in a long list of differentials. So on the screen you can see our list, but it could be secondary to an acute kidney injury or chronic kidney disease. It could be secondary to a insulin deficient state, for example in diabetic ketoacidosis. It could be patients who are having an excess of oral intake or iatrogenic intake of potassium in those with underlying renal dysfunction. It could be secondary to the medications we're giving them through, for example, those ACE inhibitors or those ARBs. It could also be secondary to a metabolic acidosis, or it could be a aldosterone deficient state in the patient, so for example in Addison's disease. As Shifona's just said, it could be secondary to a pseudo-hyperkalemia, so it could just be hemolysis in a test tube sample. And then we also need to consider some of those rarer causes that we haven't talked about today, but conditions such as tumor lysis syndrome, rhabdomyolysis, congenital adrenal hyperplasia, and your renal tubular acidosis type 4.
Next, let's talk about the ECG changes we see in hyperkalemia. The ECG changes that we normally see are progressive based on the levels of potassium. The initial changes that we see are tall tented T waves. As potassium levels climb, you then experience loss of the P waves. Further increases in potassium will lead to a wide QRS segment, and finally, the rhythm will progress to either a sine wave pattern or interventricular fibrillation.
On screen, you can see the local guidelines for the management of hyperkalemia in Salisbury District Hospital. For patients with a mild hyperkalemia, so a potassium of 5.5 to 5.9, all you need to do is consider the underlying cause and consider monitoring that potassium level to see if it is climbing into treatment range. When potassium levels climb to above 6, but are still less than 6.5, that's kind of your moderate hyperkalemia. In this situation, we want to perform an ECG on this patient. If the patient has any signs of any ECG changes related to a high potassium, and generally you'll be looking for the peak T waves in this kind of lower range of hyperkalemia, then they'll need typically treatment with IV calcium gluconate, and the dose of that is 10% 30 ml IV. Although note, if the patient is taking the digoxin, we generally put this in a 5% glucose infusion over 20 minutes. Once we have stabilised the myocardium and we've given treatment to fix the ECG changes, we now need to think about fixing the underlying hyperkalemia. The first thing we can do with this is an insulin glucose IV infusion. What this does, as we discussed earlier with insulin and its effect on cell membranes in bringing potassium into cells, is it takes all that extracellular potassium and it forces it into cells, artificially lowering the potassium levels. Generally, we'd give an insulin glucose infusion, and this would be 8 units of ACRapid in 100 ml of 20% glucose over 30 minutes. Although note, of course, you're giving insulin to these patients, and therefore it's really important to monitor their BMs. If their blood sugar is less than 7.0, then you also need to be giving them 10% glucose alongside this treatment, as otherwise you risk putting them into hypoglycemia. You can also consider salbutamol nebulizers, and as we discussed earlier, this is because of that beta agonism effect driving potassium into cells. So we've driven the potassium into the cells, and now we can also consider trying to remove potassium from the body or trying to decrease absorption of potassium into the body. One of the mechanisms we have to do this is a drug called Lokelma, which essentially is a potassium binder in the GI tract, which therefore helps decrease potassium absorption. And then we also need to be considering that if patients aren't responding to these treatments, we need to be considering seeking expert help for the consideration of dialysis. Once you have fixed the potassium, you then need to look for those underlying causes and monitor closely. Thank you for watching our teaching session today. We are your hosts, Harrison
And Shifona.
See you next time.
Don't forget to fill out the feedback form in the description.